focusing their conversation around pediatric palliative care. Dr. Antonia Bennet is an associate professor in the Department of Health Policy and Management at UNC Chapel Hill. She's faculty director of the UNC Patient Reported Outcomes Core and a member of the UNC Lineberger Comprehensive Cancer Center. Her research interests include implementation of patient-reported outcomes in oncology practice, clinical trials, and comparative effectiveness research, qualitative research, and psychometrics for the validation of PROs, and outcomes assessment in palliative care populations. We are so grateful that Dr. Bennet is also the director of our PCRC measurement core and provides regular advice regarding study measures and study-specific challenges, identifying measures that are relevant to palliative care and end-of-life populations, providing centrality and standardization of outcomes, measures, and metrics in study conceptualization, design, conduct, and analysis. And many of us go to her regularly with questions with respect to measures. Accompanying her today is Dr. Julie Childers, who's completing a hospice and palliative medicine fellowship at UNC Chapel Hill. And while she's trained as a pediatrician, she enjoys practicing full spectrum palliative care and hospice care. She's a member of the National Health Services Corps and plans to practice primary care pediatrics alongside palliative care with a dual focus on children with medical complexity and young adults with cancer. Her research interests lie at the intersection between pediatric palliative care and complex care. And with a background in computer science, she's particularly interested in quantitative research within palliative care. And we're always grateful to have people engaged in computer science as a part of our palliative care research community. So with no further ado, thank you so much, Dr. Bennet and Dr. Childers, for joining us today, and we look forward to hearing from you.
Thank you, Dr. Ritchie. We'd like to start with a description of our learning objectives, and then I'll give some background to motivate our discussion about patient-reported outcomes in pediatric palliative care. Our main takeaways from today's webinar include a discussion around the many challenges to patient-reported outcome assessment in pediatric palliative care. We will highlight some key considerations in designing patient-reported outcome endpoints for pediatric palliative care trials. And then we'll introduce the PCRC instrument library, followed by a discussion of gaps and opportunities in pediatric PRO instrument development. As we know, palliative care itself is a relatively nascent field of medicine. Pediatric palliative care is even less mature, still ramping up across the US according to the most recent published survey. Interestingly, patient-reported outcome instruments were first designed to measure health-related quality of life among healthy adults. It was only not until later that their use was appreciated in the setting of adults with chronic illness. And similar to pediatric palliative care, pediatric PROs are following behind. Pediatric palliative care is meant for any child with a life-threatening condition, and it's available in different capacities in different regions of the country and the world. Support of a child's family is a basic tenet of pediatric palliative care that is also relevant to patient-reported outcomes. A child's family is often closely involved or even fully relied upon for outcome measurement in the pediatric setting. The fact that pediatric palliative care may be delivered throughout the span of an illness journey, from time of diagnosis through death, regardless of disease-directed treatment choices, provides for continuity that can benefit patient-reported outcome measurement when longitudinal assessment is desired. The interdisciplinary team is key to addressing a child's physical, emotional, and spiritual needs. These three elements of the biopsychosocial model of health, the physical, emotional, and spiritual aspects, were laid out half a century ago in the World Health Organization's updated definition of health, laying the groundwork for thinking about health in terms of function, and in turn paving the way for patient-reported outcomes. Next slide, please. A little bit of background for thinking about patient-reported outcomes in pediatric palliative care. These days, there are roughly 500,000 plus US children eligible to receive pediatric palliative care due to serious illness or life-threatening conditions, and about 10% of them die per year, according to recent analyses. More than half of these deaths occur in infancy, many in the first weeks to month of life. And the number of eligible children is growing as a result of new treatments and technologies and an improved understanding of certain rare conditions of childhood. In terms of age breakdown, 41% of children who receive pediatric palliative care are in their first year of life, and roughly 13% of children are older than 18, often because of a chronic condition that began in childhood. The most common conditions among children receiving pediatric palliative care are categorized as genetic, congenital or neonatal, neuromuscular, and neoplastic. Next slide. Thank you. In terms of where pediatric palliative care is provided, delivery setting can vary widely. A child can remain at home and receive pediatric palliative care services in a clinic or through home visits. Children may be admitted to the hospital and receive palliative care for an acute illness or injury, for exacerbation of symptoms or progression of disease, for scheduled admissions, and even for an end-of-life scenario in which a child or family desired that death occur inside the hospital. Pediatric palliative care can also be delivered in a facility or in a dedicated hospice unit, though these settings are both less common than home and hospital. According to a 2012 national evaluation of pediatric palliative care among U.S. children's hospitals, pediatric palliative care was found to be a predominantly in-hospital service. Of 162 children's hospitals, which is about 70% of those surveyed, approximately 61% of them reported the presence of a pediatric palliative care team, and they happen to be mostly clustered in the eastern half of the United States. The majority of pediatric palliative care teams reportedly serve in an inpatient consultative role, mostly limited to weekdays, and often with some form of outpatient presence that could include phone support alone. Next slide, thank you. The same study showed that 30% of programs offered home visits and 20% reported a dedicated palliative care clinic. Few programs are solely based in the community. Then when it comes to end-of-life care, inpatient hospital-based pediatric palliative care is one of a variety of options. Children can also access end-of-life care through hospice, either at home or in a long-term care or inpatient hospice facility. Unfortunately, very few hospice programs provide child-specific services. One way to categorize the medical conditions that palliative care eligible children face is into the following 4 groups. First, there are children for whom death is possible despite the goal of cure, such as cancer, from treatment or the cancer itself, or organ failure in either an acute or more chronic setting. A second group includes illnesses with known early mortality, but that with proper treatments preserve some function, such as cystic fibrosis and certain types of muscle disease. Third is the group of progressive and incurable conditions that severely limit function despite adequate treatment. And finally, the fourth group describes static conditions with severe and irreversible impairments, such as cerebral palsy, which affects motor function and is often accompanied by other neurologic impairments. Regardless of the disease category, there are a number of reasons we might consider outcome measurement among children receiving pediatric palliative care. From the clinical side, we might want to ensure that the children we are seeing are receiving high-quality care, and that we're satisfying the tenets of pediatric palliative care, addressing their symptoms, supporting their families, and so forth. And if not, we'd like to know about our shortfalls and improve on them. Our ability to highlight high-quality care will help generate additional program support and funding. From the research side, we'd like to rely on concrete assessments of new treatments and interventions and have a systematic way to evaluate our care models. In fact, the Pediatric Palliative Care Research Network recently published a set of key research areas in pediatric palliative care that specifically includes outcome measurement as well as improvement in systems of care among the top 7 research priorities identified. Some of the research challenges that were identified in the same report from the PPCRN, Pediatric Palliative Care Research Network, include patient diversity and small population size as one challenge, interdependencies and dynamic interactions between child, family members, and disease processes over time as another, and outcomes and measurement as another challenge. So pulling that apart, in a sense, the outcomes and measurement challenge specifically results from these other challenges. The first is related to sample size, which is like rule number 1 in pediatric palliative care. The sample sizes are small and groups are heterogeneous. This makes it inherently difficult to make comparisons among or between cohorts, especially because not only does age play a role in disease trajectory, but trajectory itself is often poorly predictable. So it's unlikely that even a well-designed outcome measurement tool will be broadly usable. Next slide. Thank you. It is also very common in pediatric palliative care that patients themselves are not able to complete their own outcome assessments. As I noted earlier, almost half the children receiving pediatric palliative care are age 1 or under, and a large proportion of the older children will either be too young for reliable self-reporting, which is currently considered under age 6, if not older, depending on the reporting tool, or they're incapacitated from a critical illness, or they've already experienced static or progressive neurologic injury or incapacitation. In these cases, reliance on family members and clinicians is the key component to outcome measurement. However, it turns out the literature has shown poor agreement between child, parent, and clinician dyads. Let's look at an example of a child who'd be old enough to complete her own outcome assessments with her mother's help. We're seeing a 9-year-old girl with junctional epidermolysis bullosa, as well as mild developmental delay. Her disease involves her trachea with recurrent granulomas, and then she gets pain flares in her feet, which will lead to decreased walking and affects all of her activities of daily living. Dressing changes also are especially uncomfortable, as I imagine they are for any kid with EB. There's a concern for behavioral component to her pain. There's some school avoidance, attention-seeking behaviors at home in the setting of a new baby. And then she gets her outpatient, she gets care from an outpatient palliative care team in their clinic, and they would like to make sure they're doing everything they can to adequately understand and address her pain. In terms of her treatment regimen, she's essentially maxed out on gabapentin, also on a relatively high dose of duloxetine. She takes Motrin and Tylenol as needed, and that fluctuates based on her pain and whether it's flaring. Her mother is hoping to avoid opioid analgesics, anticipating that eventually she'll need them and that it will likely be a long-term relationship. She does get some relief, surprisingly, from steroid bursts after glottic debridement procedures that she gets every 3 months. And then her pain is currently flaring. She's progressively less able to do her daily activities. It started with just not being able to walk up the stairs, but then she kind of stopped taking herself to the bathroom at night. However, she's still able to enjoy time in the pool. She'll swim, and she'll even be able to jump and bounce without expressing any pain. So as we think about best next steps for this young woman, we might consider questions like, how can we better understand her pain? And how can we optimize resources and ensure high quality care coordination efforts from the palliative care clinic standpoint? The challenges we face are around choosing a pain metric and when to administer it, whether there are any other symptoms that are worth evaluating simultaneously, such as anxiety in this patient's case, how to measure overall quality of life in a child with a rare disease, and how to evaluate the care process, which is especially vital in the pediatric palliative care world. So next, Antonia will talk about how we can address some of these challenges that are all too common to pediatric palliative care trials.
Great, thank you, Julie, for providing a clinically focused introduction or overview of pediatric palliative care and the example of epidermolysis bullosa, which, as you mentioned, includes measurement challenges that are very common to pediatric palliative care contexts. And so now I'd like to present a set of key ideas or considerations that make up the foundation of patient-reported outcome assessment in clinical trials. And we'll focus on issues that are relevant to pediatric palliative care trials, and then look again at this example of epidermolysis bullosa to illustrate how you might proceed in planning the outcome assessment for a new trial in a disease area and a context that you're particularly, that one of our listeners is particularly interested in. Next slide, please. Oh, I'm sorry. Previous slide. Great. So I always like to start at the beginning. Most of um, most of this will be focusing on patient-reported outcome assessment and tools that can also measure concepts that are highly relevant to patients. I'd like to start at the beginning with the definition of PROs. These are questionnaires that assess topics a patient can report about his or her own health, such as symptoms, physical function, symptoms of mental health, and multiple domains of quality of life. And at the bottom of the screen is an example of a question from a patient-reported outcome version of the common terminology criteria for adverse events, which is often used in oncology. And this has been presented as, in the past 7 days, how often you do have stomach pain? And the child is asked to respond, never, sometimes, most of the time, almost all of the time. Next slide, please. So the FDA has put a lot of thought into patient-reported outcome assessment because these are increasingly used as endpoints in regulatory trials, in the evaluation of new drugs, and some of the thinking and definitions that have come from the FDA's focus on this area, I think are also very valuable to interventions that are not necessarily drug-based. So we have multiple different kinds of clinical outcome assessments, and PROs are just one of them. There are also observer-reported outcomes. The observer is typically a caregiver, and in pediatrics, this is often the parent. Clinician-reported outcomes are often used as measures of disease severity that are completed by a clinician using an established checklist or a set of rating scales. And lastly, performance-based outcome measures can include functional assessments that are conducted in a clinic by a practitioner, or they could focus on the child's activity or function in their daily life. An example of this would be having children wear activity trackers in between study visits. So the child's age, or more specifically, the reading ability and cognitive ability of the child are really important considerations in deciding how to measure an outcome in a trial. For example, can the child read well enough to complete a questionnaire on their own? But in planning the outcome assessments for a clinical trial, I think the first set of decisions to make is about what to measure. So let's start there. I recommend that when you are considering which outcomes to measure in a trial, make a list of relevant outcomes and then rank them in terms of how distal or proximal they are to your intervention. For example, if you're a drug that improves nausea may also improve quality of life. And in this case, nausea is the proximal outcome. Quality of life is more distal. An intervention that reduces readmissions may have a strong effect on readmissions, and which may also subsequently lower the costs of care, but the cost of care is a more distal outcome. Another example is an intervention that reduces a caregiver's anxiety and depression. Those would be the proximal outcomes, and then the distal outcome may be complex grief, which is known to be a sequelae of which can be exacerbated by the presence of anxiety and depression at the end of life of the patient. Interventions, this is important distinction because interventions will have a greater leverage on proximal outcomes compared to distal outcomes. So it will require a much larger sample size to have evidence of an effect on a proximal outcome. And this is partly because there are many other things that can impact the distal outcome. We think about quality, a drug that improves nausea, which will improve quality of life. There are also many other things that could improve quality of life, such as things that interventions that may reduce depression, changes in the patient's physical function. When an outcome is a multidimensional construct, it can be much more challenging to demonstrate a change in that outcome when your intervention is only designed to target one of those constructs. And then moving on to the second point on this slide, it's important to carefully consider whether your most proximal outcomes have value to stakeholders. Sometimes stakeholders find the more distal outcomes more compelling. So when you're planning a trial, have a lot of conversations with your clinical and methodological collaborators and your senior mentors about which outcomes will be your primary and your secondary study endpoints. You can also set up consultations with the PCRC Clinical Studies and Methodology Core about this important decision. Just like to mention that because the PCRC has a variety of resources for investigators planning trials. Next slide, please. So let's turn to our example and sketch out how we might plan the endpoints for a randomized clinical trial. And I would like to say ahead of time that these next few slides, giving the example of this RCT, you could consider this very preliminary planning, sort of a rough draft, but I wanted to illustrate how you might, a good order in which to do things when you're starting to sketch out and plan a trial for your own intervention in a population that you're focused on. So the first step really is to define the study population, because that has implications for so many of the latter decisions that you'll be making in your trial design. And the next is to decide on the overall objective for the trial. So in this example, let's say we're evaluating a new medication that reduces the frequency and extent of lesions in patients with moderate disease. Once that is pinned down, sort of the overall objective of the trial, then you can start thinking about making a list of potential key outcomes. And you can arrive at these through your own understanding of the disease and the disease process and the intervention, through literature review and talking with stakeholders. You may be particularly interested in several outcomes. In this case, I think a disease severity score may be an example of a proximal outcome. And then pain and quality of life are subsequently more distal, but they're arguably very important. And then you should keep track of other potentially relevant concepts during your planning process. They may become key mediating or moderating variables, such as the role of anxiety. Or you may decide that certain issues should be included as secondary endpoints, such as different aspects of treatment burden, such as time spent on changing dressings or frequent clinic visits, or treatment side effects. This is so that your trial provides a really complete assessment of the intervention's value. Next slide, please. So once the scientific objectives and the concepts of interest are pinned down, now it's time to transition to thinking about the data collection plan. And this includes the outcome instruments, the schedule of assessments, and how the assessments will be administered. For example, there are several considerations relevant to our trial for EB, and there are probably many others, but we wanted to start with at least one slide of considerations. The first is that most rare diseases do not have disease-specific quality of life instruments. EB is actually an exception to this. It's a very rare disease, but there has been over the past 10 years a growing body of literature, several new instruments that are designed to measure outcomes across a set of highly similar conditions. I think that in terms of age, we're looking at 8 to 12-year-olds This age group can complete PROs. Some may need assistance. And part of this is that oftentimes children with severe illness may have missed a lot of school, so their reading is behind, and they may also have cognitive deficits, which also may delay their reading development. In many pediatric conditions, the parent report of signs, those are visible symptoms and behaviors, are likely very valuable information as well. When thinking through a study design, I also really like to ask about the schedule of visits for the trial. For example, if a psychosocial or behavioral intervention may have, the intervention itself may have a predefined schedule of visits. A drug trial may have a schedule of visits based on the dosing routine, and that's really, if you can tie your assessments to those clinic visits and do the assessments while the patient and while the child and their parent or caregiver are in clinic, then you have just solved yourself a large set of problems around data collection. So if you can have them complete the assessments while they're in clinic, that's very often a terrific choice. And then if the questionnaire reporting from home is needed, there are now a whole host of technology and logistic questions like, do the patients and family have home internet access? And then there's also an additional layer of, not just the technology, but thinking about access and protection of human subjects research among children. Will the parents be the recipient of the email link, or the other? Will the parents be gatekeeping the child's participation in the questionnaires? Both because you may want the parents to have control over that, and the parent can also provide the structure that the child may need and some assistance that the child may need in completing their questionnaires. And on the side of the slide, I've included this flow diagram of study objective, concepts of interest, and the data collection plan. Because it's very easy when you're planning a trial to sort of get turned around and make changes to one aspect, and that may have big implications for the other plans that you've made. In particular, if you decide to change your objective, your study objectives, or change your concepts of interest, then you'll likely need to completely reconsider your data collection plan. And you can think of these as upstream and downstream decisions. Next. Oh, great. There are several measurement properties that are very important to consider. There is quite a bit that's been written about these, and there are several references that I've included at the very end of the slide deck where there are very readable discussions of these measurement properties, and also very accessible introductions to the different statistics that we use to measure these. So I would recommend that you become familiar with those. These are validity, reliability, sensitivity, and responsiveness, which I think is often overlooked. Sometimes we focus so much on Cronbach's alpha as a measure of internal reliability of the instrument. When I'm looking for PROs to put into a trial that's going to measure change over time, I'm actually most interested in the responsiveness of the measure. If there's been an improvement in the child's pain, will the instrument be able to detect that? And then another key issue is a minimally important difference. And that is thinking about how much change on your pain scale is actually clinically meaningful and would be, a motivating result if you were to find that your intervention could produce that much change in pain among the children who've received the intervention. Next slide, please. So instruments are valid for a particular context of use. So validation studies of an instrument are specific to the context, the disease, the population, and the setting that the validation testing was conducted in. So a pain instrument for pediatric oncology may not be valid for a pain study among children with juvenile idiopathic arthritis. And so once an instrument has been shown to be valid, it's not therefore valid for everything else from that point on. And so the way to think about it is whether your instrument is fit for purpose. Will it be able to measure change in this concept in your study population? Next slide, please. And instruments can vary widely, even though they may be called very similar things. Many pain scales have very similar titles. Many quality of life scales have very similar titles. I want to illustrate how different they can be. I'll show you two conceptual models for instruments evaluating pain. This first one is measuring pain quality. It's broken up in, and it's going to focus on different sort of feelings related to pain, like aching, dull, itchy, numb, or tingling. And if we look on the next slide, this is actually looking at the severity of pain and how pain impacts different areas of someone's life. So it's pain severity and interference. Just by looking for instruments based on their title, you would not be aware that the instruments are actually so dramatically different in what they're focusing on. Next slide, please. There are a number of different key aspects of assessment to consider as well. There's the schedule of assessments, the location in which you plan to conduct the assessments, and location is really a big challenge when your study participants may need assistance, or they may not have sort of their own internet access, or may not be people you can easily reach by telephone. The mode of administration can be, there are a lot of decisions you can make that can make the study much more accessible or less accessible to the patient population. And then the respondent thinking about whether it's child report or parent report. And then self-administered or interviewer administered. And I think in pediatrics, very often interviewer administered can be a good option, or thinking about having a brief protocol to describe how much parent involvement you would like to have in the child report if they are primarily completing it themselves. Next slide, please. And the care setting, as I said, is very important to think through very carefully. Regular visits in an outpatient setting, structuring the assessments around that can be very valuable. In some cases, having patients in the inpatient setting can improve the feasibility of the assessment, because the research assistant can approach the patient while they're in the hospital, if it's a longer visit, but that's not often the case for unexpected visits that are maybe short, and when the patient and family are really focused on the reason for that particular unexpected hospital visit. And in a long-term care facility or hospice unit, you need to think carefully about the patient's ability to self-report. And if you're including caregivers in the study, either as thinking of a dyadic study, looking at the patient's well-being and the family caregiver's well-being, also the ability to be in touch with their family members. Next slide, please. The last major issue, saving the best for last, is assessment by age group. There is, I think this will vary, I believe, by disease because of the amount of time children are often out of school, or because of developmental delays that may be related to their condition. So I'd like to speak a little bit about the literature that we have in oncology. There was a systematic review that provides a bit of the landscape prior to 2017. A systematic review by Tomlinson found they concluded that they had found no instruments that were valid and reliable in oncology for children with less than 8 years old for measuring cancerous symptoms. And then subsequently, the NCI's Pediatric Pro CTCAE has been published. In their developmental work, they did some very focused cognitive interviewing of children in very small age bands. They looked particularly children ages, say, 7 and 8 years old, and they found that they were able to complete the questionnaire items. And some subsequent work by Janice Withacombe and Bryce Reeve has also really identified that it's really literacy is a key construct in determining people's ability to complete PROs. But oftentimes we focus on age because that's much easier to define in study enrollment and SOPs. So I would encourage you, if you're for the disease area that you are focused on in your intervention study, to look to see what has been done with the quality of life or symptom instruments specific to that pediatric population. And if it has not been investigated rigorously, then potentially draw from the findings of other disease areas. Oncology is often, as it did in adults, I think it's also really leading the way in or there's been quite a bit of work in instrument development in pediatrics and oncology. And so I think some inference can be made between what's worked well in oncology to what may work well in other significant diseases. Next slide, please. Lastly, I'd like to touch on resources that are available through the PCRC to help investigators find good quality instruments. Next slide, please. Great. So the instrument resources of the PCRC are divided into, you'll find them in 2 different sections. The caregiver core contains instruments that are relevant to caregiver research. So if the caregiver is the subject, how's the caregiver feeling? What are their symptoms? What is their anxiety level? What is their well-being? Those instruments are contained in the caregiver core. In the measurement core, we have an instrument library composed of instruments relevant to patients when the patient's the subject. And that may also include instruments where a caregiver is reporting about the patient. We have both an instrument library, and then as we develop the instrument library, we have a growing list of systematic reviews of instruments relevant to palliative care. So you can look at the source material there. Next slide, please. So the PCRC instrument library currently covers a number of domains relevant to palliative care. We release a new version every year. Up until now, it has focused on adults, and then we're really excited to be releasing our annual update at the end of this month that will have a new section composed of instruments for pediatric research. Next slide, please. And so the library has about 200 instruments for assessing patients and their care. We have populated the library by identifying with instruments that have been identified by published systematic reviews. So we have instead of conducting a massive systematic review ourselves, we have looked at systematic reviews because they're so time consuming that have been conducted for very specific topics, and then looked at the conclusions of those authors in these peer-reviewed papers. And so instruments that are highly rated by that systematic review are then added to the PCRC library. And we include information about the content, the number of items, and several other aspects like the recall period, whether it requires an interviewer, the estimated completion time, and then key citations to PubMed so that you can find the papers describing the instrument in detail. Next slide, please. So this is just a screenshot. This is currently, the instrument library is currently an Excel file that can be sorted and filtered based on the characteristics of the instrument that you're interested in. So if you're interested in communication, see in this screenshot, there are 3 instruments that focus on communication that you can see here. And then for other instruments, you can further sort whether they are disease specific or not. Next slide, please. So to access the library, if you go to the PCRC homepage and click on the cores and centers, a link in the menus tab, and then use the drill down menus. If you look under measurement core, then you'll see there's a link for the PCRC instrument library. Next slide, please. The library is available to members and non-members. And then once you complete a very brief online request form, it will be emailed, a copy of the file will be emailed to you immediately. Next slide, please. This past year, we also conducted a scoping review of pediatric quality of life instruments. These again were instruments included in published systematic reviews and rated as high quality by that review. And we've identified quite a number of gaps in the available instruments. These include symptoms other than pain, psychological symptoms, social aspects of care, ethical and legal aspects of care, cultural aspects of care. There's quite a lot of work to be done around instrument development to support pediatric palliative care research. Next slide, please. And so we've identified several opportunities. One is to adapt and test existing measurement instruments from older to younger age groups, including adapting some adult instruments where that may be feasible. Another approach is to adapt existing disease-specific instruments for use in children with other serious illnesses. For example, if two illnesses had fairly similar symptom profiles, then a symptom instrument or quality of life instrument from one setting may be amenable, may be fairly easily adapted to another disease area. And lastly, measurement development in the domains where we really have very few instruments that have strong psychometric, strong measurement properties that have been published so far. And our approach with the instrument library is, while there are many instruments that are available, We have required that there be evidence of, published evidence of validity and reliability. There are often instruments that have been used for many years, almost sort of by word of mouth or almost sort of by tradition, but we really encourage investigators to really investigate the quality of an instrument before you go ahead and include it in your trial, because you want to make sure that the instruments you're using can really reflect, can really pick up and reflect the value of the intervention that you're testing. Next slide, please. Great. So we'd be glad to take any questions at this time.
Thank you, Dr. Bennett and Dr. Childers, for a fascinating presentation. Let's wait just a few minutes for the questions to come in. And please do so with the Q&A feature at the bottom of your screen.
Maybe while we're waiting for questions to come in, I want to thank Antonia and Julie for your presentation. And I'm interested in how you navigate measurement validation issues given the incredible spectrum of ages that constitute pediatric palliative care.
I think what's occurring in pediatric instrument development is there's a desire to sort of push the threshold sort of lower and lower. So if you found that 9-year-olds understand your instruments, well, what about 8-year-olds? What about 7-year-olds? And then there is a well-established technique that we use in instrument development, the cognitive interviewing, which is when you do sit down with an individual and have them read the questions and sort of repeat back to you in their own words, what do they think the question means? And this is really well suited to determining comprehension of the questions. And I think that's comprehension of the questions and also the ability of a child of that age to formulate an answer to the question. And that can tell you so much about whether they will be able to provide, meaningful and reliable answers on the written questionnaire.
Great. Looks like there's some good questions coming in. Naomi, you want to go through them?
Yes, how do you suggest selecting PROs when your sample includes those who are both under and over age 18? Much of my work is in the AYA cancer population, or those 15 through 29.
That's a great question. In oncology, there is work being done to look at whether older adolescents, sort of 16, 17, 18-year-olds, can understand sort of the adult versions of the symptom instruments. So comprehension is one piece. And the other piece is content validity. You could imagine in a quality of life instrument that the concerns and priorities of adults may be different than the concerns and priorities of adolescents. So I think if you're looking at symptom instruments, you may be more likely to be able to administer one instrument across your whole study sample. And then for quality of life, I think you'll have to look carefully at the instruments and think about, and also ask adolescents, are these the issues that are important to you? Or are there other things that are important to you that are not reflected in these instruments?
Thank you. There has been some debate about the utility of validating measures, given the vast amount of time and effort in doing so, with some feeling it is sufficient if the measure has been used and published previously, but without the standard application of psychometrics. What are your thoughts on measure validation in light of these pros cons?
Um, I think that there's so much time and effort and resources that go into a clinical trial, thinking about all the different aspects of it, um, that, um, and in the development of your intervention, that I think it's I think it's crucial that your outcome measures are are known to be good measures. Can they detect improvements in your outcomes of interest? Because without that, without without good instruments, you might as well not run the trial. Um, and so there there is there is sort of some middle ground on development and validation of instruments. The work that goes into developing and validating a brand new instrument is definitely extensive. It's time consuming. It can take, even in calendar time, a couple of years. And then there's also the process of determining whether an instrument from another population is appropriate for your trial population. That often takes less work, but I agree it still takes time. Um, if um, uh, if an instrument has been used frequently in a disease area, but the development and validation work hasn't been published, or it was published 20 years ago when there wasn't so much consistency in the field, I think it is worth going through each of the criteria of what's considered a valid and reliable instrument and making sure there is evidence for each of those pieces. That can be taken from the original development and validation work, even if it has gaps. And then sometimes some of those gaps can be filled in by looking at how the instrument performed in clinical trials. So was the instrument able to distinguish between the group that had the intervention and the group that didn't? Was the instrument able to pick up change that occurred over time, which was evident from both maybe that instrument and maybe some other measures that were included in that trial? So you can use the evidence from published clinical trials to demonstrate some of the psychometric properties of your instrument, and that that can certainly be a more efficient way to establish the validity of your tool, and then to have that information so that when you're submitting a grant and proposing to use that tool, you can document that it is in fact valid and reliable for your trial.
Thank you. And of the 200 PCRC instrument list, how many pediatric instruments are likely to be included?
We have, I think it's about 20, I think it's 20 or 22 instruments in this upcoming release that are pediatric focused. And this is largely a result of there being so few pediatric instruments currently. And then we're also looking at instruments that have been included in a published systematic review. So it was this endeavor to build out the pediatric section of the library. We knew there were going to be gaps, and it's very clear now that the gaps are quite extensive. Obviously, there's tremendous need for additional instruments in pediatric palliative care research.
Thank you. So I think all other questions can be sent to Dr. Childers and Dr. Bennett through their email addresses, which are provided on these slides, and these slides will be posted on our website. We want to thank everyone who's joined, and thank you again to our speakers. If all of our attendees do go to our website, we have 2 more webinars that are posted for the near future. Next up, we have Doctors Diane Fairclough and Laura Porters presenting So Now It's Time for the Analysis, How to Make It a Good Experience. Then in August, we have Dr. Zara Cooper presenting on challenges in palliative care and the surgical patient. We hope that you join us for those as well. We will be sending out an evaluation where we gather other topics that you might be interested in learning more about. So please take a minute to fill that out. Thank you again to our speakers and to all of our attendees for joining. Take care, everyone.